president of the ISPN, a lot of publications, chapter books, and welcome, Dr. Tadanori. Privileged to introduce you, and good job.
Thank you, Neothi. It is a great topic. It's a very challenging topic, and I'm glad the Education Committee of ISPN picked this specific one. Middle cranial fossa arachnoid cyst need to be operated or not, unless there is progressive symptoms. And this is still remains quite controversial, and some say yes, operate proactively, or others may say just wait until what happens. Now we do have a wonderful two speakers. First, George Jallo is professor of neurosurgery and pediatrics and oncology at Johns Hopkins Hospital, and he's now joined in the All Children's Hospital, which is now affiliated with Johns Hopkins. And he's head of pediatric neurosurgery, but also he directs Institute for Brain Protection Sciences, which is a multidisciplinary pediatric neuroscience program. And he's also leading this neuroscience team, but also he's a physician-in-chief at the same hospital. He was graduated from Virginia Med School and a residency at the NYU, and took a fellowship with later Fred Epstein and Rick Abbott. And he has been stayed on in NYU, but moved to Baltimore and now in Tampa, Florida. And his main interest is the brain tumor, and he runs a very nice basic research lab. And now another distinct, the presenter is Giuseppe Pepe Cinalli, and he's from Naples. He's a native Naples Italian, and he graduated from University Federico II of Naples. And he was trained for his residency under Professor Faust De Andre. And then after that, he took extra training at Necker in Paris. And is under the direction of Professor, late Professor Jean-Francois Hirsch. And he spent there as a faculty for 6 years, and subsequently, he, actually 8 years, he returned to Italy, and first Santa Maria Hospital in Terni, Italy. And in 2007, he moved back to Naples. Since then, he has been the head of the pediatric neurosurgery service at the Santo Bono Post-European Children's Hospital in Naples. So we have a wonderful two distinguished person, particularly Pepe is now actually past president of the International Neuroendoscopy Society. And I think we have great distinguished presenters, and just we'd like to learn today if we should operate or not operate for this so-called asymptomatic middle cranial fossa arachnoid cyst. So probably George goes first, and then Pepe goes second, and we have a discussion afterward. Hey, Sandeep, welcome.
Sorry, Ted, I was held up because I had to take the vaccine, and they wanted me to remain in the hospital for 1 hour after the vaccine to make sure I wasn't breaking into an anaphylaxis.
Yeah, so I'm glad you're alive. So after vaccine, right?
So I don't know whether somebody's introduced the Ted, but I just take a few minutes to introduce Ted to the audience. That Ted Tomita requires an introduction to any pediatric neurosurgeon on this planet. But Ted is a man who I think his life is of many paradoxes. You know, for one, he comes from a family of military people that he decided to do medicine. Second, very interestingly enough, he arrived in the United States. I don't know whether he chose the date, but if I remember from his ISPN address, that he arrived in the United States on the 4th of July. Was that sheer coincidence? I don't know. But thereafter, he's never had to look back in his life. And of course, he's done lots of great things at the Children's Memorial Hospital in Chicago. You know that he's a professor. You know that he was the president of the ISPN. He, in fact, held the position that I hold now in the ISPN before he became president. He was chairman of the Education Committee, which is when perhaps I was first introduced to this amazing gentleman, because he's a person who has combined the clinical achievements with
Sandeep, you are muted. Sandeep, I think some technical issue going on your side. Thank you very much for your introduction. And I think for the sake of the time, let's start Dr. George Jallo's presentation.
Thank you,
George.
Ted. Thank you, Sandeep and Nelsie. Pepe, welcome. I guess I get to go first, and I get to speak about the topic of the male cranial fossa, Sylvian fissure, arachnoid cysts. Best to leave them alone. I think I might have the advantage on this, Pepe, so thank you for allowing me to choose the conservative route for these asymptomatic lesions that are presented to the neurosurgeon. And I do want to thank Sandeep as well as the ISPN for inviting me and hosting these educational webinars, because I find them extremely interesting and I've learned a lot from them. So I think, just as a little background for everyone, we all know that they are benign. They're not neoplastic. They're extraaxial. So why should you even operate on them at best? I mean, these lesions are filled with fluid, CSF, and the majority, 3/4 of them are found in children, more likely to be in boys than men. A lot of times, they're found on imaging studies, whether it be a CAT scan or MR, for an incidental finding. After a little trivial head fall, a trauma, a injury, blurred vision, headaches, and they present with this arachnoid cyst. And then these children are referred to our offices. And what do? So I think embryologically, we all recognize that it's typically seen at around the 15 weeks gestation, the precursor to the pia mater and the arachnoid. There's some pulsations that go through this meninx primitiva and separate incompletely and form these arachnoid cysts. So, what are the treatment options, right? Observation, we could always recommend just serial observation if we're going to do that. How often do they need to be seen? Surgery, if you're going to do surgery for these asymptomatic cysts, what are the approaches? Is it a craniotomy for fenestration? Should we do an endoscopic approach, or should we do a diversion procedure, a cyst to something shunt or something other, where some people have reported just aspirating or draining these cysts. So there are many options to manage these benign approaches. Historically, I think we have to go back to the early 80s when the Sylvian fissure arachnoid cysts were first reported, and the Galassi classification of the different types of Sylvian fissure. And this was one of the first reports in the early 80s, looking at 31 cases, 7 of which had at that time CT metrizumide. You can see the MRI above, as well as the CT dye study. In 1988, they expanded their numbers to include 77 cases that were treated surgically, and that the authors again, proposed their classification based upon the size of the cyst. At that time, they're advocating surgery. However, even in that early series, there's a mortality rate of 1%. And when you look at it, a mortality rate, yes, it's low of 1%, but it still is 1% for a benign cystic lesion. It's not as if it's a malignant aggressive brain tumor or not. So really, having just one death, in my mind, is a significant complication. The other is when you look at their complications, you could see that they had significant subdural hematomas, hygromas, intracystic hematomas, and even epidural hematomas following surgery, and that the indications for surgery just included a cranial deformity in some, which in my mind is asymptomatic. So more than half of them were asymptomatic in their early series. So, I think the ISPN actually did a survey back in Ezio and Giampiero did a survey of the community in 2008, looking at a almost 3-year-old boy with a type 2 left Sylvian Fisher arachnoid cyst, and they presented different scenarios for the participants. And they had about 45 centers that responded to this. And the question was, if this child was asymptomatic, what would the recommendation be? If the child had headaches or if the child had seizures, what would the recommendation? And clearly, if this was an incidental finding, 75 to 80% recommended observation alone. So incidental finding, no symptoms, less than 20% recommended surgery. If there are headaches, about 40% recommended surgery. Seizures, another 30% would recommend surgery, and psychomotor retardation was 30%. So for the incidentally asymptomatic, 80% of surgeons would not advocate for surgery. And then their recommendation was, whether you followed it or not accordingly. So again, if it's an incidental finding, how do you follow it? When do you do the scans? And how often should they be seen? I think, that was 2008. We fast forward to 2015, and we look at this, this paper that came out and saying, look, we need stricter indications for the recommendation for surgery for these cysts. They looked at, in 11 years, they looked at 75 patients, and again, this was a mix of both Sylvian Fisher as well as other locations, knowing that predominant location was the Sylvian Fisher. Looking at these patients over 11 years, 75 patients, what they found was that surgery was unsatisfactory. And when they looked at it, and I'm not going to talk about what the outcome was. Let's just look at the complications, and you can see here that the complication profile is high for if one does surgery, including subdural fluid collections in 25%, a cranial nerve palsy or temporary weakness in up to 10%, spinal fluid leak, which 5%. A significant hemorrhage in 5%, and an infection in 3%. I mean, when you add up all these complications, looking at this series, I think the results, if you look at it, is, there is a significant risk profile when you operate on these children, especially the ones that have no symptoms. Another study shortly thereafter in 2016 looked at it at the long-term study, looking at these, again, children. They looked at 27 children, and they all had they had symptoms, some of which were headaches, some had macrocephaly, hydrocephalus, and of these 27, 22 underwent microsurgical resection, and 5 went endoscopic fenestration. They followed them, and what they for about mean follow-up of about 9 years. And what they said that 77% were improved in at least one symptom, but subjective symptoms remained in 60% of these patients. So, again, their findings, similar to the prior study, was that Our findings support a restrictive attitude to surgery for intracranial arachnoid cysts in the absence of objectively verified symptoms and signs or obstruction of CSF pathways. So if we're going to talk about asymptomatic children, how about the neurocognitive effects of these middle cranial fossa cysts? Because there are many surgeons that advocate for surgery on these children to show that children with these cysts suffer from neurocognitive decline and that surgery will improve their testing. And this was a series out of Seoul again, and it looked at 24 children pre and post, and they looked at the the WISC as well as the BGT test, and they looked at it whether it was on the right side or the left. And here it is. You know, if you look at it on the scores, there's scores pre and post-op on these children. There's really no difference operating on these cysts, regardless of their size. And you can see, you know, where the location was, it temporal, frontotemporal, or mainly frontal, and what was it, endoscopic versus a microscopic approach. And again, I think I just got to bring light. You know, their complication profile was high, and some children required multiple procedures. So I think, you know, when we look at this, and you know, and I can show you this, if you know, as you look down, you can see all the additional surgeries that were needed to be performed on these children. So it's not as if you do one operation, you're done, and that these children are going to get better. No, I mean, you know, I've shown that their cognitive profile does not improve dramatically, if not stays about the same, and that there are complications associated with surgery. Another paper that just looked at, again, the neurodevelopmental outcomes and compared them to a control group. And what they found was that the children with these large arachnoid cysts is similar to the control participants in neurodevelopmental function. However, a subgroup of the children with cysts had an increased risk for poor outcomes in general function, and that really, if we're going to consider surgery, all these children should be tested prior to surgery. So then, you know, let's talk about the effectiveness of the procedures, the surgical procedures that are available. You know, and what they looked at was just the effectiveness of microsurgical fenestration for middle cranial fossa cysts, and this was a study in 2016 out of Japan. They looked at 28 patients, and what they said was that the cyst decreased in size in all cases, 100%, and in some it completely disappeared, but very less than 10%. However, 80% developed subdural hygromas, and could be symptomatic in some. And some of these cysts, some of these complications required additional surgeries. And then I think, you know, what's more importantly is this study actually recommended that you really should be careful if you're going to operate on these very young children with these middle fossa cysts. When they looked at 21 children with these middle fossa cysts after fenestration, what they found was that if they were operated on less than 2 years of age, that almost 15% developed subdural effusions and or hydrocephalus, and that almost half of them required additional surgeries, while the older children were less likely. So I think we've got to be careful if we're going to recommend surgery, even in the younger children. So yeah, as I close out, I'm going to just talk about, well, what about adults? So you know, does it make a difference when these children become adults? And they looked at this study, and what they found was that, again, there is no improvement following surgical treatment in adults with intracranial arachnoid cysts. And I think this paper that was just recently published in 2020, when you exclude patients with hydrocephalus or papilledema, there's no outcome between the surgery and non-surgery groups, regardless of the size of the arachnoid cyst. And this looked at 60 patients, again, coming from Korea, and said there was no difference in this population of children. And then, you know, I think looking at the meta-analysis, and just for time, I'm going to skip it and go to my final thoughts for this. And this paper was just published this month. And we heard that maybe the endoscopic approach is better, less invasive, and all for these arachnoid cysts, because that's what we were recommending early. And what this experienced group found was that really that endoscopic arachnoid cyst fenestration is safe and effective, less invasive, and high success, low permanent complication rates. However, the temporal basal, the Sylvian Fisher arachnoid cysts, are the most difficult to treat endoscopically. So these are different than what we read about in the suprasellar or other locations. And they looked at it, looking at their 87 patients, 31 of which were in the Sylvian Fisher region. And what they found that if you looked at this, the highest complication and the recurrence rates, were found in the most frequent temporal basal cyst location, and that the pure endoscopic technique should be abandoned for this location. And you can see that their complication profile was 21%, with more than one complication in 2 cases. So I think, honestly, my conclusions are, should we really continue to operate on these cysts? And I think we still don't know which children are going to benefit from surgery. And I think we should continue with the observation. And I do want to thank you, Tad and Pepe. I'm going to give the ball to you to tell me that we should be operating on them now. Tad, I think you're muted.
Yeah, thank you, George. That's a wonderful presentation. It's a great literature review, and the most of contemporary the literature certainly indicates that some concern of post-operative complications of particularly subdural correction. This is always the concern, but how about Pepe says? Do you agree what he said?
I did a fantastic speech that was extremely good and extremely easy to follow the stream of what is being said in the last years. Do I share my screen right now?
Okay, please do that.
Yes, and of course, I thank the ISPN for giving to me the place of the bad guy who should play the bad position. And I have no disclosures, and except that I feel very, very lonely in this position because, of course, the last 5 or 10 years have been very much in favor of conservative treatment to any price. And in my personal practice, I am a very good and nice and conservative guy.
Yes,
in the last 5 years.
I am present, and I'm sorry I've been delayed. I had to take the vaccine and stay for 1 hour.
I think there is a return from Tad in the microphone.
And today's date being the
29th of January.
Sorry.
2020.
Can I continue?
No, I think that is Sandeep. Sandeep, would you mute yourself, please?
Okay. So in my personal practice, in the last 5 years, I have only operated on 13 Sylvian cysts, 9 endoscopically and 4 with microsurgery. And I had 2 complications, one subdural that was treated by subdural peritoneal shunt, and one stoma obstruction requiring a second microsurgical procedure. So I consider this, out of my practice of an average of 580 cases a year, 100% pediatric, as a very conservative management for surgical indication on Sylvian cysts. So I basically share most of what George said, but there are some dark spots that would be nice to see and to see maybe a little bit better. Wait a second. Okay, this is better. Indication for surgery. In the title, we talk about progressive symptoms. and is non-progressive symptoms insufficient for surgery? And basically, what is a symptom in temporal arachnoid cysts? Certainly, as George said, they are a very frequent finding with subtle and insidious symptoms, so no lethal disease, certainly, and the straightforward surgical indication is exceedingly rare, and there is a general trend to leave it alone very, very strong in the last 5 years of literature. If we go to look all the traditional symptoms that had been considered as symptoms for surgery or indications of surgery, slowly, one by one, they have been contrasted by some of the evidence in the literature. The only one that is still in favor of surgery straightforwardly so far is presence of hydrocephalus and presence of papilledema, but so far, maybe that in the next years we will also see some papers coming out that will show that we don't have operate on Sylvian cysts with this kind of feature. But for the moment, surgery is not debated in the presence of hydrocephalus and papilledema. Macrocranial and focal bony bulging also, they had been considered as symptoms, but slowly they have shifted from symptoms to non-important findings. Focal bony bulging now cannot be considered anymore as an indication for surgery, and even progressive macrocrania that was considered as a clear sign of increased intracranial pressure in the last years has been considered as a less important sign, certainly not a straightforward indication. And then there are a lot of vague symptoms. The developmental delay, we will see it later because it goes mainly with the principle of the cognition. And epilepsy certainly is one of the hotspot. Should we consider epilepsy as a progressive symptom or a symptom at all in the Sylvian cyst? This is a very controversial issue. Many papers say that there is no correspondence between the seizure focus and the presence of the cyst. That is correspondence only in 23–25% of the cases. So that would account for the success rate after surgical decompression in seizure outcome. And the same author said, and interestingly remarked, that the temporal lobe arachnoid cysts usually are not associated with temporal lobe epilepsy, of course, and they conclude that most cases the cysts are an incidental finding. This is against other papers in the literature that find that there is a significantly higher proportion of arachnoid cysts in the focal epilepsy group, this paper from Serbia, and so they conclude that arachnoid cysts are probably seen more often in patients with focal epilepsy. So focal epilepsy should raise our attention when we discuss about surgical indication in an epileptic patient with an arachnoid cyst. But there are other papers on the population like this very nice paper performed in South America, showing that finally performing a CT scan to a whole village, to a whole small city, the number of the temporal arachnoid cysts that were found, if compared to the and matched with the epilepsy of that population, found that there was absolutely no correspondence, and that was in favor of lack of association between subarachnoid cysts of the temporal lobe and the seizures and epilepsy. Evidence that seizures are mostly controlled with anti-epileptic drug in most of the cases when seizures are associated with arachnoid cyst. So certainly it is a controversial issue. Up to 30% of patients undergoing surgical treatment are affected by seizures in traditional and historical series, and improvement rate after surgery is exceedingly variable. It ranges from 0 to 80%. So it is a debate that is very much ongoing, but certainly it is due to the absence of a real recent systematic review and a very large series about the matter of epilepsy and middle fossa arachnoid cyst. And in a paper from Italy, where 40 patients had been treated endoscopically, 8 of them were presenting with seizures, and in this small arachnoid cyst series treated endoscopically, 7 epileptic patients improved after surgery. So this is some point that should be kept into account. Improvement can exist and can occur. So patients should be studied carefully and not disregarded as a simple association between epilepsy and arachnoid cyst. In this paper, talking about only cystoperitoneal shunting, EEG abnormalities only improved in 10 out of 42 patients, and 21 out of 26 epileptic patients continue medical treatment with anti-epileptic drugs. So certainly the treatment with the cystoperitoneal shunt is not so much effective, and the rate of improvement in this series was probably not higher than the rate of a normal epileptic population in the long term. But there are certainly case reports, many case reports of complete resolution of medical refractory after temporal lobe epilepsy and arachnoid cyst penetration, mainly after decompression of the cyst. And this has been looked at in a more systematic way in 1998 by this German group and German and American group. They did a worldwide review of the literature concerning arachnoid cysts and seizures. They found that in the worldwide literature there were only 76 arachnoid cysts operated for seizures available for a careful literature review. 57% had Sylvian locations. And they found that in this very highly selected case report or a small series, the results of the seizure surgery, intending for seizure surgery decompression of the arachnoid cyst, when there was a significant reduction in the volume, there was a much higher improvement, up to 76% of seizures in the patient, if compared to patient where the arachnoid cyst was remaining exactly the same, where only around 50% of improvement was noted. So controversial and interlocutory findings in this literature review that of course cannot draw any conclusion. And the natural also thing that was found by epilepsy surgeon was that the early epilepsy surgery is performed, the better the seizure outcome. So epilepsy and arachnoid seizure and arachnoid cyst certainly are points that are important to study. Most studies investigate presence of the cysts in epileptic patients. Small cysts and cysts without mass effect are frequently included. So there is no precision in this study, and no study specifically investigates outcome of epilepsy in patients with large middle fossa temporal cyst, and certainly there is a coexistence of epileptic fossae and arachnoid cyst. In the last years, we have seen a couple of case reports of a subdural grid placed in the depth of an arachnoid cyst. So finally, an arachnoid cyst with epilepsy studied with the same application and method of epilepsy surgery patient, and epileptic fossae were found in the depth of the arachnoid cyst. In the condition of keeping the subdural grid was a technical issue, but it was resolved in these cases, and also in this other case. In the first case was some kind of foam that was used. In this case was glue, but the addition of the grid to the cortical surface was excellent. And in these two cases, patient with arachnoid cyst and seizure treated like epilepsy surgery, the fossae were found, were removed, and the outcome of seizures was excellent. And the same thing also in this other paper. So in temporal arachnoid cyst and seizure, there is a risk that epileptic patients carrying a temporal arachnoid cyst could be discriminated because of the presence of the cyst. These patients are not screened as ordinary epileptic patients. Epileptic fossae are only searched with the scalp EEG, so the depth of the cyst is not explored and can be shown with difficulty that there is some epileptic fossae. Patients are labeled too easily as incidental finding, and epileptic Sylvian cyst patients undergoing standard epilepsy surgery workup can be counted on one hand's fingers. So there is something that certainly can be done. When you do a Medline search associating a stereo EEG and arachnoid cyst, you have no results found. And when you do subdural grid and arachnoid cyst associated, you only found 3 results that I have reported in the earlier slides. So certainly there is something that can be done to improve this, and even this case is the only case that I have found where a patient with an arachnoid cyst has been treated for his temporal lobe epilepsy, also with some technique of temporal epileptic surgery, and in this case it was even done in Bangladesh with a very good result for his temporal lobe suture. Certainly this is a very special case, but it is the only case available in the literature to the best of my knowledge. For the headache, pathophysiology of the headache, I listened to George earlier saying that a patient presenting without symptoms or only with headache, but many of these patients have a severe and a chronic headache. Is there a mechanism for this headache? Intracranial hypertension, intracystic hypertension, local regional hypoperfusion, and global hypoperfusion. Intracranial hypertension has been demonstrated by the group of Ezio Di Rocco in 100% of Galassi type 3 and 50% of Galassi type 2, only 11 patients, certainly very small group, but the pyramid is very, very interesting, and 0% of Galassi 1 had intracranial hypertension. Of course, there is a limitation of the methodic. It is an invasive methodic, and the electrode is placed quite far from the cyst, but still it was positive and it corresponded well with the size of the cyst. Intracystic hypertension also, this was quite surprising. The intrapressure cyst was measured, and it happened to be much smaller and normal, closer to normal than if compared to the group of Di Rocco that were only with the children. And probably it is due to the fact that the cyst pressure were considered only after 3-5 minutes after puncture of the cyst. So probably there was some leak decreasing the pressure of the cyst, but certainly it is a little bit higher than the normal intracranial pressure. Local regional hypoperfusion has also been demonstrated with many radiological methods, in this case with a series of technetium, but also with the more modern and less invasive MRI. You can clearly perform that in the area around the cyst and even far from the cyst, there is some hypoperfusion, and even this can be global, as demonstrated by Skouros and Chapman at the beginning of this millennium. They showed that there were not only pericystic decrease of blood flow, but an overall general tendency to decrease blood flow into the whole brain and to the basal ganglia. So with this data, should we consider headaches as a progressive symptom in a Sylvian cyst? Because this is a very important matter. A lot of patients with Sylvian cyst present with a headache, and many of them are advised to go home with their headache because the surgery is not indicated for them. So what is the outcome of the headache after cyst decompression? In children, in the same paper cited by George before, headache resolution was observed in 100% when headache was observed as a single presenting symptoms. In another adult series of the group of Bergen, who has studied many years the temporal cyst in adults, the headache disappeared in more than 80% of the patients treated for cyst of the temporal fossa. So certainly a good result. And when this researcher did this nice prospective study on quality of life after surgical treatment of arachnoid cyst in 2015, and then they published in 2019 their long-term results, they saw that headache were significantly improved, 73% at the first follow-up and 82% at the last follow-up, as well as dizziness with an increase over time. So these are data that normally should work against the placebo effect of the surgery, because such a long-term improvement in headache and dizziness is highly possible that is not a placebo effect, but is really related to surgery of the arachnoid cysts. So headaches, in my experience, but also in the literature, resolves or improves in more than 80% of the cases post-operatively, and improvement is usually stable or slightly better in the long term, and it is much better demonstrated in the adult population than in pediatric population. Dizziness goes with the headaches as seen before, and cognition delay. Cognition delay, there is a difference between adult and children, a very significant difference. The story started in 1995 with this very revolutionary paper by Wester and Hugdahl in Bergen. Always they started to study the arachnoid cysts. 13 symptomatic patients were operated. All of them had poor memory and cognitive performance preoperative versus a control group. 12 patients significantly improved post-operatively. And the same group during the years has given offer evidence of the fact that several tests improved after surgery in concerning the cognitive deficit, preoperative cognitive deficit in adults can improve after surgery, and also this paper by the same group, the visual attention can improve in under many paradigms in a significant way. So these data are difficult to ignore completely or just to treat them as a result of the placebo effect. And this author, who was the first one to describe this in 1995 and has published so many papers on temporal arachnoid cysts, also has done a nice review of the literature and the survey indicating that arachnoid cysts may affect cognitions, and also they do so in a reversible manner as the patient cognitive impairment. So in the adults, this is the situation. In children, as said also by George, the situation seems to be completely and dramatically different. When we look at the paper by Schertz and the group of Constantini of Tel Aviv, in fact, it is very impressive what they did. 25 patients with a very large temporal arachnoid cyst, only 9 were operated compared with a group of siblings. 9 were Galassi 2 and 16 were Galassi 3. And they found that there was a trend for more patients with a temporal cyst to have a poor outcome than the siblings control, but it was a trend, it was not statistically significant. And the patients who underwent surgery scored significantly worse with regard to the VBRS total score compared to those who did not, but not on other tests. So quite a controversial issue, score worse on some tests, but not on other tests. And it is not clear if this worse score is related to the surgery or is related to the fact that the worst cases were operated and so they performed less good. Anyway, in this paper, patients had trend to worse outcome than controls, and operated patients score worse than non-operated in 1 test out of 4. Their conclusion were that children with a large temporal arachnoid cyst perform similarly to their sibling control, but that the subgroup of these with cyst did have an increased risk for poor outcomes in general function. So our efforts should be directed to identify this subgroup of patients who have an increased risk for poor outcomes, and we still do not know how to do. And they, of course, suggest neurodevelopmental assessment that should be part of the management of all patients with temporal arachnoid cyst, and it is not done worldwide at this time. And on the basis of this paper, should we consider cognition delay as a symptom or a progressive symptom in sylvian cyst? This is also not clear. And this paper also cited by George, that seems to be very strong paper studying neurocognitive profile before and after surgical intervention. 24 patients operated, tested before and after surgery. Their interpretation and conclusion were that the present findings indicated a limited role for surgical intervention in improving the intellectual abilities of children with arachnoid cysts. So at least this is a clear conclusion. But when you go to read the paper, you find amazing things. For example, even in the results in the abstract, you say that in block design showed that one of the neurocognitive tests showed significant improvement post-operatively. This means that visual spatial integration and mental construction abilities were improved after surgery. So it is in contrast with the conclusion that the authors drawn, at least apparently. And even reading inside the paper, you even identify a subgroup of patients. That is not a small group, because group aged less than 7 years showed a significant difference in neurocognitive profiles after surgery in measuring sick, verbal comprehension, subtost, and block design. So this data is, even in this paper, remains controversial. And also this paper that is also very nice, an incredible paper describing 20 years of, or even more, of surgical and non-surgical management of arachnoid cysts. 60 patients over more than 20 years, 38 who were operated were compared with 22 who were not operated. 8 operated patients had surgical complication for a complication rate of 21%. Not operated patient had no surgical complication, of course, and no one of the observed patients crossed over with the average follow-up of 7.5 years. So this is certainly in favor of observation instead of aggressive behavior. And the conclusion that surgeons should refrain from offering surgery because this procedure could not provide any benefit. Unfortunately, this conclusion is being proposed without any of the actual parameters that we are studying. That means that in this paper, there is no IQ or developmental quotient evaluation, no cognition evaluation between pre and post-op, no social insertion, no school performance evaluation, and no quality of life evaluation. So it is only based on the cyst size. And the cyst size, we know very well that is not sufficient to be considered as an outcome measure. We need something more from the large sylvian arachnoid cyst, and no one of these data is unfortunately available in this fantastic paper that gives a lot of surgical information, but no information about the cognitive evolution in the long term. Other paper on the same size are talking about completely different conclusion. For example, this very recent paper on March 2020, 15 children with temporal arachnoid cysts were evaluated. 13 had a lower than normal cognitive testing. 1 refused, 1 electrocuted, 11 were operated, and all patients had improvement in all testing, and in 7 out of these testings, the difference was significant. So significant post-operative improvements was observed in many of the testing, and certainly this is a paper that is completely controversial and completely opposite to the findings of the other papers, and even other smaller series, like in this case, the psychological situation of neurosurgeons now is that they are traumatized to propose surgery, because in this series of 3 patients, 3 of them improved their cognition. Look what the poor author writes, that we have not found any other reason for this change except for the decompression of the arachnoid cyst. So they almost seem to excuse themselves for operating this patient and for observing such a result. So certainly there is a trend, but we should always keep our mind free from the trend and from the fashions, because we still do not know enough about cognition in my way of looking at things. There is a great confusion in the very recent literature. There is a highly controversial data that are emphatically presented as conclusive. Highly respected institution drawing opposite conclusion from similar raw numbers, and there is certainly a very significant fracture line between adult and pediatric literature. So where are these children growing to become adults? So why there is such a difference? and why there is not a larger interest for this pathology and for the cognitive evolution of this pathology. So let's go back with the last few slides to the facts about the size. The callus type 1 are not surgical lesions except with hygroma, and everybody agrees with that. The discussion on surgical indication should be limited to Galassi 2 and 3, and this is also certainly a fact, and we should consider and evaluate case by case. Preoperative cognitive testing should always be included in the surgical decision tree. This is very clear now, and we cannot study or propose observation or surgery without a careful preoperative cognitive testing. And symptoms should not be ignored or underestimated. We cannot say, no, just has headache, oh, he just has some developmental delay. This must be considered because this pathology has very subtle symptoms and can be overlooked in the worsen possibly in the long term, in the very, very long term. About the headache and the seizures, when the headache is the main complaint, surgery is effective in the long term in 70–80% of the cases. This is my personal experience and in most of the authors of the literature. When the seizures are the main complaint, cyst decompression is rarely effective. I have only one case that was effective, but it's very, very small experience. But certainly further options of epilepsy surgery have never been offered in large numbers, and we should start to evaluate if this patient should be studied in a different way and treated in a different way by simple cyst decompression. On the cognition, the effects on the cognition are controversial. Even the most conservative papers describe not negligible rates of post-operative improvements. So we have to really make the difference and understanding what is going on, and at least identify the subgroup of patients that can benefit under the cognitive point of view. And there are too many well-documented case reports, or more serious to ignore them in the literature, and good candidates to decompression certainly are difficult to spot preoperatively, and we require more reliable test battery. We do not know, there are no protocol for cognitive testing before surgery, so we should certainly improve our knowledge about that. And about surgery, George said everything. I just will add that complications are certainly frequent, especially when the cyst is large, and the three options, microsurgery, endoscopy, and shunt, we should tailor them to the patient. I have a clear preference for endoscopy, but microsurgery is certainly should be regarded as extremely effective, and in many cases, in many series, has been described with fewer complications compared to endoscopy, and sometimes shunt can be an option in a very, very rare exceptional patient, and always tailor the technique to the patient. And to conclude, I feel more and more lonely after this talk. But certainly concerning the original question, if the middle fossa arachnoid cysts without progressive symptoms are best left alone, I would conclude saying the humble suggestion that presenting symptoms should not be underestimated or denied. Symptoms do not need to be worsening or progressive for surgical indication. Do not disregard a patient who seeks your attention for a headache or for some mild developmental delay, because there could be a relation, because we still do not know, and the evidence in the literature is not clear enough yet at this time to exclude the relationship between the cyst and some cognitive delay. Asymptomatic, really asymptomatic, is really incidental, Galassi 2 and 3, at least should not be left alone and should at least undergo cognitive testing for as a humble suggestion. Thank you very much to everybody.
Thank you, Pepe. It's a wonderful presentation, and this is a lot of things. And we are more confused after listening to two of you. And so when you say the symptom, I think primarily you're talking about what is the true symptom. Some kid bumps the head, get the CAT scan. Oh, here's a big arachnoid cyst. Or ENT surgeon look for the sinus disease and get the CAT scans, and there's a huge arachnoid cyst behind. Otherwise, a student. So or else maybe ADHD patient and neurologist fed up and get the imaging and there's a large temporal arachnoid cyst. Otherwise, kids running around crazy. Still, we are not sure what is a true indication. Our biggest concern of this temporal arachnoid cyst, I think we do the surgery, and I prefer to do the microsurgical fenestration. And now we are creating iatrogenic subdural because of the surgery. Now, that iatrogenic subdural versus so-called traumatic subdural rupture of the arachnoid cyst, are they the same or different?
George, you want to answer? I mean, I think that they are completely different. I mean, the number of spontaneous rupture, in my experience, is certainly lower if compared to the number of subdural hygromas that I have created treating the cysts. So certainly the problem is that the subdural collection, when you read some papers and you talk about 80% complication with a 60% of subdural collection, this is not my experience. I mean, very frequently these cysts are decompressed, and sometimes there can be a film of subdural collection, but then in most of the cases disappear spontaneously. It is extremely rare that we have to shunt them. And this happens, this occurs to everybody and also to me, of course, but consider radiological subdural film as a postoperative complication is not adequate, I think, because most of the patients are not reoperated. These are completely asymptomatic, and they are very difficult to avoid.
It's George. I have to agree with you. I mean, in my experience, you do see this. I think they're hygromas. I don't think they're subdural hematomas following surgery. And most of them will resolve if you are patient and give them time. On occasion, and it's the exception that they do become symptomatic, but it's very unusual in my experience. I mean, I think in the ones I've done, I'd say it's 1 or 2 cases I've had to operate on that subdural collection.
Yeah, talking about the spontaneous leak of the to the subdural space from the ruptured arachnoid cyst, right? George, you're talking about?
Yeah. Oh, yeah.
So, yeah, there's some kids present with 6 nerve palsy and throwing up everywhere, headaches. Those things, how do you treat?
You know, I sometimes have used, again, when they do present that way, sometimes I'll put them on a prolonged course of steroids, a little decadron, see how they resolve. It's only if they fail that would I then consider surgery for them.
Yes, this is part of I mean, a headache patient with an arachnoid cyst should always before be screened by the headache clinic, of course, to understand if there is some other reason for headache, of course. But when they come back after 1 year or 2 years of attempts of change of 2 or 3 headache clinic because they don't find a solution, I mean, depends on also the family of the psychiatric profile of the patient, and that's why a good neurocognitive testing is really necessary. Headache clinic, but also neurocognitive profile. But then at the end of all this, if headache remains, and I have no doubt about the neurocognitive point of view, headache for me is an indication for surgery.
Okay, thank you. You know, I have one question from the audience. The Ramiro from the Brazil. In my experience, I saw a couple of arachnoid cysts that presented significant growth after some time. Do you recommend to perform any control? I think I suspect maybe observe with MRI. If you agree, how much time would you wait to do so? And do you suggest to operate on in that case? Either one of you?
Yeah, it's George. Personally, I've seen very few arachnoid cysts grow. When I do see them, the first time I see them, I always get a follow-up MRI, but it's not until, it's usually somewhere between 1 to 3 years after the initial. And I will say, I don't, the number of arachnoid cysts that I've seen grow is 1 in several hundred at best.
I agree. I agree, and cyst enlargement is not per se a surgical indication. It always depends on the of the clinic. Why this patient presented for the first MRI, and why is he doing the follow-up MRI? Because these are the real reason for asking yourself for surgery, I think.
Sorry, the Ramiro is from Argentina, not Brazil. Now, so totally incidental, let's say head bump, football player found to have the large temporal arachnoid cyst. And usually it's happened on the left side for some reason. Do you follow the patient with MRI? Just sending it home and just go home? Do you follow those patients with follow-up MR?
What kind of patient you said? A patient who?
No, let's say maybe the preteen kid who struck his head, and then otherwise he's absolutely normal headaches after trauma, and good size. Let's say glasses type 3 type large arachnoid cyst. How do you follow this patient? And do you send the patient back to the football field? Maybe this doesn't matter.
I follow them with certainly one MRI in the long term, let's say 1 year or a couple of years after, and certainly at the same time a new neurocognitive profile, at least basic neurocognitive profile to be compared to the first diagnosis. Then I don't give any advice. I just inform the parents and the child himself, if he's more than 14 years old, that there have been reported ruptures of the cyst following head trauma, following football, following boxing, and so they should be aware of this, and they will decide freely what to do. But it's up to them. It's not up to me to say don't do football anymore, because this is nobody can say that. I think people have our aim is to give to this patient a life as normal as possible. If to a 15-year-old boy you say stop football, in Italy is not very well seen. I mean, it's so you can give advice of play football, but avoid to hit soccer. I mean, we play soccer. I don't know what is it about American football in the States, George, but we usually advise of leading a normal life.
Pepe, I know we were supposed to, disagree on this. I do exactly the same thing that you do with that scenario, Tad. I counsel the family; it's their decision. But as long as, and I document that, I discuss, with them the risk of a hemorrhage. But I don't tell them they can play. I don't tell them they can't play. I do want them to lead a normal life.
Okay. Now, when do you operate on this patient? What is the absolute indication for the arachnoid cyst operation for the temporal cranial fossa?
What are the indications for surgery?
Yeah. When do you operate? When do you recommend the surgery?
It's a discussion, it's a long discussion with the patient and with the family. This is not a lethal disease. It has been shown that this patient can perform very well throughout their life. They can reach very high academic targets, and they can have a very normal life with a good quality of life. So they have to come to me to explain what is their symptom and what is their problem. Then I can tell them if it is headache and the problem is only headache. In this case, I cannot guarantee the resolution of your headache, but there are very good results. If the problem is epilepsy, my attitude is different. It's different because I have never placed a subdural grid in the same way these guys have done very nicely. I would probably not propose straightforward decompression without the possibility of doing some kind of monitoring in an epilepsy situation, because if this is the only presenting symptoms, our results are not so good. Okay. And literature as well. So mainly depends on the, it is not a straightforward decision from the surgeon. This is an indication that should be, how to say, put together with the family and with the patient, according with their expectancies.
Right. George, what do you think that what is absolute indication for the treatment of this temporal arachnoid cyst?
So again, I think I have to agree with Pepe. For me, the indications is if I see there's papilledema and there's no other indication for it, a sixth nerve palsy, and I've seen that with these cysts. Seizures, you know, that are referable to that area. I also do not put grids in, but I will do a prolonged video EEG to see if we can capture them from that location. So I think, you know, those would be the three hardcore things I would recommend surgery. Headaches, I'm with Pepe. You know, it's go to headache clinic, see if you can manage it, come back, and if it, you know, if they fail, I'd be honest with them. I'm just, you know, although, you know, the literature suggests that it'll get better, I haven't seen that in my experience, that, you know, that their headaches, you know, that we're going to promise them their headaches are going to improve. And then the neurocognitive, I have mixed feelings about that. I'm not a believer in saying that we're going to improve the neurocognitive if they have compromise on their testing.
So if the patient showed parents concerned, this fifth grade kid, he used to be a student, now dropping the grades, and finally he was found to have a large left side temporal arachnoid cyst. Otherwise, no papilledema. Most of the time, no papilledema anyways, unless it's ruptures. Do you guys let it be? Let's say you do a neuropsychological testing. Okay, clearly something wrong with this kid, and neuropsychologist cannot figure out, or maybe this is the temporal arachnoid cyst is causing it. Do you operate on this group of the patient?
For me, no, I don't. But Pepe, it's up. I'm not sure what you do.
I am very. I would like to be so sure as you. You know, just saying no. If someone comes with, for example, it has been described in the left arachnoid cyst, discrepancy between the verbal IQ and performance IQ, significant discrepancies. And this with a much lower verbal IQ and much higher performance IQ. And just to remain very simple, very basic cognitive test. And these discrepancies has been demonstrated in several cases to improve after cyst decompression. So I decide case by case, George. I am more and more. We started to study really systematically under a neuropsychological point of view 5 years ago all our cysts, and I am more and more in favor of careful evaluation. Of course, we are not talking about psychotic disorder. We are not talking about autistic disorders. This psychiatric, this is not real neuropsychiatric problems. This will never, I mean, I have never seen improvement after surgery. But some degree of neurocognitive problem I have seen improving, and somehow I have a tendency to believe to what people write. So it's if even 1 out of 3 improves, at least I talk to the family and I explain that to the family.
Yeah, very similar question from the audience. Which is your experience, how you proceed with a patient with Galassi 2 or 3 cysts with behavioral issue? I think you answered, but still I'm not clear what you do the best. Clearly, kid is having a trouble. The parents are suffering from that, and I'm not sure if indeed there is a disease to blame, that is large temporal arachnoid cyst, particularly on the left side, which is more common side than the right side. We just let it be. Again, the surgical complication, we talk about it, and we are creating iatrogenic subdural collection. And so I agree, this happens, minor trivial head trauma to just dive into the pool. And it's a relatively common thing. We reviewed about 35 patients over the past 10 years, which we operated on for the cyst fenestration. And about 30% presented with a leakage, the subdural effusion, rupture. And those patients tend to present a much sicker one. And sometimes we can wait by the simple steroid. This is, I think, George like to hold off the surgery and try to use steroid or other, maybe Diamox or other things, like treating a pseudomeningocele almost. But I think when the kid is very sick, I do not know. I would operate on that group of the patient. But I do not know if we wait. Sometimes they improved, sometimes put the external subdural drain and just certainly clear up that all the symptoms. But that is ultimate solution without doing the so-called cyst fenestrations.
Yeah. Certainly there is a lot that we have to do to improve and standardize our techniques. Because this rate of complication is not acceptable for a surgery that is not aiming with a lethal or a dangerous disease. And we should try to tailor better our surgical technique to the patient. There are patients that could not be operated endoscopically. And when the frontal lobe goes too down, or where the angle of the temporal lobe is too much anterior, and you have to work too much in the depth of the temporalis muscle, I would not advise for I do endoscopy, and I am past president of the Federation of Neuroendoscopy. So, but there are cases that I do not treat endoscopically. I prefer microsurgery. Serious complication like middle cerebral artery injury, or a bleeding from a perforating artery, or a lesion to the third cranial nerve, these are unacceptable for this surgery. It should never happen, never, because it's really, if you do a careful microsurgical approach, you really have a complete control of the anatomy with good instrumentation and some experience. This complication really should never happen.
So Pepe, going back to that, do you do them endoscopically or microsurgically? I mean, for me, I've tried both. I much prefer to do these Sylvian Fisher arachnoid cysts microscopically. I think the opening is not much bigger than the endoscope. But I'm able to achieve a wider opening, and my operative time is actually much less than with the endoscope. So I've now converted. I used to do half and half, and now I'm exclusively microscopic for these Sylvian Fisher cysts.
Yeah, I think that certainly the the Sylvian cysts are the more stressful endoscopic procedure that I perform. It's definitely because, first of all, because the patients are well. So I study the patient with a coronal drive or cyst sequence, looking for the anatomy of the membrane. If I have very nice membranes to perforate with large windows between the carotid and the optic and the third that are clearly visible in the cyst sequences, then I opt for the endoscopic procedure. But if I am not confident with the anatomy and with the windows to perforate, the windows must be perfect because the arachnoid cyst, the wall is very thick. So it's not easy to perforate with the endoscopic. Yeah. So sometimes you have to use a sharp instrument, and sharp instrument so close to the middle cerebral, that's what stressed me. So I prefer in difficult case, more difficult cases, I definitely prefer microsurgery.
Yeah, I agree with that. You know, there's such a thick membrane. You push at the medial wall of the arachnoid cyst instead of poking with the endoscope. So we need two hands, push at the membrane and then open it. So I think most of people agree that the microsurgical technique is...
Can I just ask a question to the panelists? With your permission, can I ask a question to the panelists?
Please.
So I was just going to say that, you know, I have a young teenage boy who had a trivial trauma on a playing field. Let us not worry about the type of sports he was playing, and then ends up with a subdural. After a trivial trauma, there is a suspicion that he's got a type 2 or type 3 cyst underlying this, and his subdural is drained. He's perfectly well. He gets a repeat MRI after 6 weeks, and that shows that he's got a type 3 cyst. He's totally asymptomatic now, perfectly normal, no neurocognitive problems, no neurological deficit. Would you go after that cyst, or would you leave it alone?
Perfectly asymptomatic, you say? Perfectly
asymptomatic.
With a 6 months follow-up, probably I would leave him alone. And if there is the subdural is completely resolved.
It's been drained.
Drained. Okay. This is a good clinical case. No, normally not. I'm thinking about my practice, and I usually don't do that.
George, would you agree with that?
So Sandeep, yeah, I mean, I would just, it's up to the family at this point. I would say, look, you know, I don't think this needs treatment, but you also understand he's had a subdural from a trivial fall. If they're willing to accept the risks of surgery, then I would probably proceed. Although I would favor not doing surgery though, if that makes sense.
So if you knew, if we have the scenario, and I'm talking about 2 scenarios that I have faced in the last 6 months. You have a child now that you know has a type 3 cyst, who now has a fall and has a subdural. Would you now drain the subdural and attack the cyst in the same surgical procedure? Or would you just drain the subdural? He's got a hemiparesis after the subdural. Or would you drain the subdural and watch the cyst again?
For me, in that scenario, I do both at the same time, the subdural and drain this and penetrate the cyst simultaneously.
Pepe?
I did it only once, the same, to treat the 2 at the same time, and it worked very well. But otherwise, since I do not treat the subdural in the emergency because I do not do on-call anymore, the other guys drain the subdural, and then we. So this is not a good answer because there is a regional and a local situation. So it's they prefer to drain, but I prefer also to drain, and then because this adds risks, you know. When you operate a cyst in an emergency situation, I think that doubling the surgical risk for a patient who is absolutely well and then must be really well, I don't think it's good. But I mean, depends if George wants to wake up at 2 o'clock in the morning, he's much younger than me, so you can do both at the same time.
Chad, I am asking this question because Chad is just looking at all his series of arachnoid cysts, which is a lot greater than ours. But we have about a dozen children who've presented with subdural hematomas. We've drained the subdural. We've never touched the arachnoid cyst. The longest follow-up I have is 21 years, and he's never had another subdural again.
Yeah.
So this is why I question whether at all one needs to do anything to that cyst just because they've had a subdural after a trivial trauma.
Sandeep, we are talking about subdural hematoma or kind of blood-tinged CSF.
No, subdural hematoma.
Yeah, that story is different. Maybe that creates a scar down, the arachnoid membrane scar down, so does not cause any more subdural. But so-called rupture, which is CSF with or without the hemorrhagic component, and those patients present with very acute headaches and sick nerve, and often subdural not only one side, but if we wait next day or 2 days later, the subdural is both sides of the hemisphere. Those things I operate on, and because CSF, sometimes if a kid is so sick, we place the external drain, then you know what the quality of the CSF is clear. I just go over there and fenestrate at that point. So, but subdural hematoma, it's relatively unusual to see. It can happen in subdural or intracystic hemorrhage. But I think that group of patients, probably you have to wash it anyways, right? You operate on those patients. I think you create a scar down in the subdural itself. That's not time. Anyway, that is not time to fenestration anyways. Because you open, yeah, when you even though you operate and they fenestrate, the blood clot probably plug up that the fenestration site.
Yeah. Final question I had really was, what happens if you have a giant type 3 Galeazzi cyst, which is discovered as an incidentaloma with thinning of the skull, huge midline shift in a completely asymptomatic child who's been scanned for some other reason, and this turns up as an incidentaloma? How would you follow up this child?
I would continue to do cognitive testing forever. It's you know, we grew up at the time of the size matters, and now we have to change our mind in size is not important. So I partially believe to this new wave of giant cysts to be left alone, not because people are untrue, but because the life is very long. So you study a patient for 10 years, from the birth until the age of 10 years, and you say, wow, you have a 10-year follow-up. This is fantastic. But the life is much longer than this. And, you know, I would really do as many cognitive tests as possible, looking for, I must be really reassured about that. And I would follow up this patient. I would not leave him alone, saying, don't worry, lead a normal life. Galeazzi type 3 with midline shift, if they are very big, I think must be followed up. At least followed up.
So follow-up shows, the follow-up means getting a series of MRI?
Yes.
And also neuropsychological testing?
Maybe I have no schedule basically, but I think that alternation of 1 year MRI and 1 year a full neuropsychological battery could be not too much invasive for the child, and is an acceptable follow-up if you really want to do nothing on a Galeazzi type 3.
Okay. One question from the audience: have you ever seen the facial weakness due to the arachnoid cyst of the this temporal cranial fossa?
Sorry, what you say?
A facial palsy.
Ah, facial. I have never seen. I have never seen a facial palsy.
Do I. Yeah.
I've never seen it either. I agree.
Okay. The occasionally we see that the unilateral optic atrophy. And I always ask that ophthalmologist to see not only papillary edema, but as it's ophthalmological conditions. And EEG, when I look at the Saddle is a good friend of mine, and 1990s we did the EEG, but most of the time everything is negative. So we stopped to doing all the EEG testing, unless the family suspect some sort of epileptic activities. So what do you tell the family? Okay, now here is a 6-7-year-old kid who was found to have Geraci's type 2 or 3 arachnoid cyst. What do you tell the family when he become teenage to 20-something? How do you tell the family? They like to know what the prognosis of this kind.
I think for me, go ahead.
Sorry.
Go ahead.
For me, I think once they become adults, I would say, I tend not to follow them as closely as I would their children. I mean, just living, if they've had no deficits, no neurocognitively, they've maintained their scores, go live a normal life as an adult, and nothing else.
I completely agree with George. I mean, the level of anxiety, I don't know what happens in United States or in India, but in Naples, if you give the diagnosis to the child, to the family, that there is a cyst in the brain, the level of anxiety of the whole family raises to incredible levels. And this could be a limitation for the normal life of the child. So I try, if I decide in my mind that there is no indication, I order to perform the normal life, and as normal as possible without any sport or physical activity limitation.
Okay. Sandeep, I think we reached the time. So
yeah. I think that, thank you very much. It only remains for me to thank the two speakers today. Though we call them debaters, they seem to agree on most things, I have to confess. And thank you very much, George, and thank you, Pepe, for giving your time. And of course, thank you very much, Ted, for sharing your experience and being kind enough to moderate this session. I like to thank all of you and all the audience on behalf of the Education Committee of the ISPN, and inform you that we will be back in February. So wherever you are on the surface of this planet, good morning, good afternoon, or good evening, and bye-bye. And have a much better 2021 than you've had a 2020.